Welcome back, everyone, to Decode Healthcare with Harshal. I am so excited to jump into another explainer with you today. If you've been hanging out with us for this massive 20-part deep dive into the musculoskeletal system, you'll remember that in Part 3, we tackled the really tricky codes of the head and face. Well, today we're moving down the body for Part 4. We are going to decode the CPT guidelines for the soft tissues of the neck, as well as the thorax, which is really just a fancy medical term for your chest wall and rib cage. We'll be looking specifically at CPT codes 21501 through 21899. And as always, we're doing it with absolutely zero fluff. So let's get right into it. Here's our agenda for today. We'll cover the neck and thorax soft tissues, then move right into tumor excision depth guidelines, chest wall reconstruction codes, rib and sternum fractures, and finally, wrap up with our key takeaways. Starting off with Section 1, neck and thorax soft tissues. Okay, let's dive into this. Before we even think about touching a code, we have to understand the actual physical geography of the body part we're working on. The muscular system of the neck and chest isn't just one solid block. It's actually an incredibly complex matrix of layers. Think of it kind of like a layered cake. You've got the skin on the very outside. Just underneath that, there's a layer of subcutaneous fat. Keep going deeper, and you hit a really tough sheet of connective tissue called the fascia. And then finally, underneath all of that, you have the deep muscle layers, like your big chest muscles or the thick muscles running down the side of your neck. As a coder, your main job in this section is figuring out exactly which one of these anatomical layers the surgeon had to enter. Moving right along to Section 2, Tumor Excision Depth Guidelines. Let's look at subcutaneous versus deep excisions. So all those anatomical layers we just talked about, they bring us perfectly to our first major block of codes, soft tissue tumor excisions. These cover codes 21550 up to 21630. Now, when a patient has a lump, a mass, or a soft tissue tumor in their neck or chest, the surgeon's going to cut it out. But here's the absolute most critical CPT guideline you need to remember. The most important factor isn't actually the size of the tumor, it's the depth. The CPT manual basically splits these excisions into two distinct buckets, subcutaneous and subfascial. Subcutaneous simply means the tumor is sitting right below the skin, trapped in that shallow fat layer. Subfascial, or deep, means the tumor is hiding completely underneath that fascia, that tough connective wrap, and it's buried down inside the actual muscle. I always like to think of it like digging in a yard. A subcutaneous tumor, that's like finding something just beneath the grass. But a subfascial tumor, that means you've got to dig all the way through a tough layer of landscaping fabric to get to the roots. And the CPT guidelines are incredibly strict about this rule. Their definitions explicitly state that subcutaneous excisions are confined to the tissue below the skin but above the deep fascia. If the surgeon has to actually cut through that tough fascia layer to get the tumor out, boom, you instantly bump into the subfascial or deep code family. You literally cannot code these correctly unless you read the operative report to find out exactly how deep the surgeon's scalpel actually went. So let's see how these two parameters, depth and size, actually intersect to give you your final code. For a shallow subcutaneous tumor removed from the neck or thorax, your magic number is 3 centimeters. If it's less than 3 centimeters, it's code 21555. If it's 3 centimeters or greater, you use 21552. But the moment we go deep into that subfascial layer, the size threshold actually jumps up. For deep tumors, less than 5 centimeters is code 21556, and 5 centimeters or greater is code 21554. The golden rule here, always check the depth first, and then check the size threshold for that specific depth. All right, Section 3, chest wall reconstruction codes. We're looking at codes 21685 to 21750. Now we're moving even deeper, past the fat and muscle, straight into the architectural shape of the chest wall itself. Sometimes the bone and cartilage just don't grow correctly. There are two really common structural deformities you're going to code here. The first is pectus excavatum, which translates to a sunken chest. This is where the breastbone literally caves inward, pressing right up against the heart and lungs. The exact opposite of that is pectus carinatum, which is often called a pigeon chest. That's where the sternum pushes outward. For both of these, surgeons basically have to go in and physically remodel the entire chest cavity so the internal organs have enough room to breathe. For that sunken chest condition, pectus excavatum, a super common fix is called the Nuss procedure. And honestly, this is fascinating. Instead of cracking the whole chest wide open, the surgeon uses a minimally invasive approach. They take this heavy-duty, custom-curved metal bar and literally slide it right under the breastbone. Then they flip the bar over. And when they do that, it actually pops the sunken sternum outward into a normal rounded chest shape. It's literally a structural realignment from the inside out. When you're coding this minimally invasive NUS procedure, the CPT book forces you to look for one very specific detail. Are you ready? Did the surgeon use a camera? If they just slid the metal bar in without visually inspecting the inside of the chest using a scope, you report code 21742. But if they inserted a thoracoscopic camera so they could safely guide that bar right past the heart and lungs, you report code 21743. It's such a small detail buried in the operative note, but it completely changes your code. Now, the minimally invasive NUS procedure isn't always an option. Sometimes, if the deformity is really severe, the surgeon has to perform a massive, fully open chest wall reconstruction. This means they're making a large incision, physically cutting the deformed cartilage, and manually reshaping the sternum by hand. If your operative report describes this fully open approach, rather than just sliding a bar in, you completely bypass those NUS codes and use code 21740. So always verify that surgical approach. Okay, moving to Section 4, Rib and Sternum Fractures, codes 21811 to 21825. We have officially reached the skeletal level. The number one rule of fracture coding here is knowing the difference between closed and open treatment. And remember, these terms describe the treatment, not the actual injury. Closed treatment means the doctor did not slice the patient open to fix the bone. They might have just wrapped it, applied binding, or used a brace on the outside. Open treatment, on the other hand, means the surgeon actually took a scalpel, cut through the skin and muscle, completely exposed the broken bone to the open air, and fixed it internally. They're usually doing this by drilling titanium plates and screws directly into the ribs to hold them together. You might be wondering, why on earth would a surgeon need to screw metal plates onto someone's ribs? Well, it's usually due to a really severe trauma that results in a condition called flail chest. Imagine taking a direct, crushing hit to the rib cage that causes several adjacent ribs to snap in 2 or more places. That entire section of the chest wall becomes completely detached from the rest of the rib cage. It's just freely floating and completely unstable. Every time the patient breathes in, that broken section aggressively caves inward. It is life-threatening, and it absolutely, 100% requires an open surgical procedure to plate those ribs back together. When you are coding the open treatment of these rib fractures, the CPT book bundles them beautifully based on pure math. You literally just need to count the number of ribs the surgeon plated. If they opened the chest and fixed 1 to 3 ribs, you report code 211811. If the trauma was a bit worse and they had to fix 4 to 6 ribs, you escalate to code 211812. And for massive reconstructions involving 7 or more ribs, you report code 211813. Just count the ribs in the operative report and you've got your code. It's that simple. And right in the middle of those ribs is the sternum, or the breastbone. It has its very own dedicated fracture codes, but the logic here is exactly the same as before. If it's a closed treatment, meaning no surgical opening, you use code 21820. If the surgeon actually has to open the chest to fix that fractured sternum, you drop down to code 21825. Let's wrap things up with Section 5, Final Musculoskeletal Coding Takeaways. So, what should you really take away from today's explainer? When you're coding the neck and thorax in the 21000 series, you basically have to act like a surveyor mapping the body from the outside in. First, pinpoint the exact anatomical layer. Is the tumor sitting in the shallow subcutaneous fat, or is it buried deep in the subfascial muscle? Second, identify the surgical approach. Did they use a minimally invasive camera for that chest reconstruction, or was the chest wide open? And finally, count the bones. How many ribs did they bolt back together? Map the layer, find the approach, do the math. We've just decoded the protective cage of the human body. But what happens when we leave the ribs behind and move onto the central structural pillar that holds everything else up? You will not want to miss Part 5, the spine. We'll be tackling codes 22010 through 22899, and let me tell you, it is an absolute beast of a section. It relies heavily on complex guidelines, intricate anatomy, and a lot of add-on codes. But don't worry, we're going to break it down concept by concept so you can code it with total confidence. Make sure you're subscribed to Decode Healthcare so you don't miss it. I'm Harshal, and I will see you in the next explainer.